speaker, Dr. David Beckers, please, on the Mf15 lens.
I'll put these up a little bit. That might be useful. So thank you very much for the kind introduction. This is supposed to be an update session, and to give you an update on the common disbelief that you should only keep the premium IOL to patients who don't have any comorbidities. We just did a little analysis I want to show you. So I asked myself the important questions of life, which is which lens for which patient. That plays probably the most important role in our everyday life. And we just probably have too many to choose from. And which one is the best is just always a difficult answer. And the same way you just mentioned it, if you're in doubt, well, I don't know, just put a monofocal in and then see how it goes. And we think, well, there's a better way to do it than just to put a monofocal in. Because there are ways when there are alternatives and when premium can become a standard. And for us in our clinic, the Mf15 is pretty much the standard IOL we use in every single patient we have. So it's an EDOF IOL, which works with a refractive design, is aspheric, has some plate haptics and a copolymer, which consists of a hydrophilic core and a hydrophobic surface. Therefore, it expands inside the eye very easily, very smooth and quickly, and it even fits through in 1.8 millimeter incision size, even though routinely we use 2.2. So if you think premium IOLs are only for perfect eyes, we want you to think again, because what about the patients we all have, and probably we have more of, which are these patients with glaucoma, age-related macular degeneration, epiretinal membranes, or also Fuchs endothelial dystrophy. These patients are actually the ones we see every single day, and we think to just put a monofocal into these patients doesn't give them what they could be having. So we think you should go a different way. Therefore, we did a defocus analysis of our large cohort of Mf15 patients. We are currently working on that 1 year post-op results. Currently evolving, we are up to almost 150 eyes so far. 1 year post-op, and we did a subgroup analysis of all those patients I just showed you having glaucoma, age-related macular degeneration. As you can tell, you achieve an uncorrected visual acuity of 0.6 up to 1.5 diopters near addition. And therefore, not only perfect eyes, but also those eyes benefit a lot from these lenses. Especially, we have to admit, in this subgroup analysis, there are even the worst patients you could imagine. So we have some wet AMD patients in there as well, because we don't even counsel our patients whether we put this lens in or not. So the right question remains, which optic for which patient, not which lens. And therefore, this refractive segmental design gives us the advantage that it has such a high light transmission. If you compare it, for example, to a trifocal, you have just a light transmission which is superb of 93 to 95%, which gives you a very good contrast vision. And also, if you compare it to other lenses within a halo and glare simulator to look at photopic phenomena, you can see even compared to a monofocal aspheric IOL, the vision is not worse than in these patients. So just to conclude, for us, there is no disadvantage in uncorrected distance visual acuity. So we would hate to give a patient like 6/9 for distance. So all our patients routinely get up to 6/6. We have equal contrast sensitivity compared to a monofocal IOL. They get a near addition of 1.5 diopters. And as we were talking about angle alpha, sorry, just wait for the beep. All right, and it's the only asymmetrical refractive design, and therefore you can perform an alignment to the visual axis. No other rotational symmetric IOL can do that. So if you have a large angle kappa, it doesn't matter in these patients. You don't have to look at it, because you just put the visual axis through the distance segment. And therefore, next time you think, well, which lens do I want to put in? Well, just put an Mf15 in, and then you should be good to go. Thank you very much for your attention.
Any questions from the audience? So the Mf15 is part of the you know, you have many mechanisms for EDOF.
Mhm.
So the MF15, the vivity is like, they call it wavefront. The MF15 is like a refractive bifocal segment. You have spherical aberration, you have pinhole. So it's one of those mechanisms which allow a lens to give extended depth of field.
If
So
I would like to comment on that, for me, it's one of three. So if you break it down, you have those pinhole lenses, which are a great niche product for well, irregular corneas, for other aberrations. And then you have spherical aberrations, and that concludes pretty much everything. If you look at the data sheet of every single other company producing, there are those companies which openly say, okay, these are spherical IOLs, EDOF IOLs, which use spherical aberrations, and I love that they do that, but to call it an X wave, and then if you look at it, oh, we just call it fourth and sixth, well, generation aberration, that's pretty much the same as spherical aberration per definition. So just the companies try to sell us something we try not to understand. So therefore, I would say the main group of EDOF IOL are spherical EDOF IOLs which use spherical aberration, and then in the third group we have these lenses which just use the segmental area, and therefore we just prefer it over the others on a daily basis.
any more questions, comments? Okay, thank you very much.
Thank you.